and welcome to our show, Health and Wellness, Myths and Facts. I'm Gargi Rawat. Today we're starting a series of 4 special programs focusing on women's health issues. For long, women's health has sadly not received attention due to a variety of reasons. Primary among them is the tendency of women to keep their health needs at the bottom of their priority list. The woman always prioritizes the health of her father, brother, husband and children before taking care of herself. And it's imperative that women's health is given due focus and attention so that the overall health of the family remains well, and so does the community. Starting off the first episode on women's health, we have Dr. Purvi Chawla, who works closely with women, helping them manage diabetes, heart disease, hypertension and other conditions. So if you have any questions that you'd like to ask the doctors, do send them to us on WhatsApp on the following number that comes up on your screen, and you can send us your question and also send us your name and your location. We'll get our experts to answer those questions. We're also joined by Dr. Anjali Amit Bhatt, consultant diabetologist and endocrinologist, Endoclinic Pune, and Dr. Vidhya Rajeev Jahagirdar, consultant endocrinologist, Coimbatore. Thank you so much, doctors, for joining us on the program today. And Dr. Chawla, welcome to the show, and starting the series with the first question to you. What, according to you, are some of the reasons why diabetes in women is detected late? Do they have different symptoms? Which are unique to them?
Thank you. Good afternoon, all. Once we acknowledge the fact that diabetes in women, and for that matter, non-communicable diseases or NCDs in women are different, difficult, with different disposing factors and also associated with more death, we ourselves will become the champion of our health. These NCDs are heavily driven by lifestyle choices, unhealthy lifestyle choices over a background of genetic predisposition, especially in our Asian Indian women, with higher amount of visceral or internal fat as compared to other ethnic backgrounds. Now come the COVID pandemic, and women's health priorities have completely taken a back seat. So we are passionate about increasing this awareness and motivating women towards self as well as preventive health care, so that the spotlight will be back on women's health, and we will be able to prevent disease. Women themselves have ignored their health for a long time. Now, coming to your question, women and men have differing biological as well as social attributes. The life cycle of a woman is so different that diabetes may also present differently in them. More than 35 million women in India are suffering from diabetes today and are detected late, despite the fact that the risk factors are much higher in them. Conditions like polycystic ovarian syndrome, gestational diabetes, pre-diabetes, overweight, obesity, sedentary lifestyles, menopause should be clearly recognized as high risk factors as well as vulnerable points in developing diabetes in women, so as to enable them to intervene with healthy lifestyle choices, medications, monitoring of blood sugars and also weight loss. Socio-demographic factors, which are important determinants of diabetes in women, have also worsened during the pandemic, like poverty, low financial independence with little control over the household income, low education, more responsibilities on women as the caregivers, leaving them with little time for themselves for self attention to health, and culturally unaccustomed to paying attention to one's health or spending on tests or even giving due importance to early signs and symptoms of disease, or even accessing free health care. Society glorifies the self-sacrificing nature of women, and this has led to delayed diagnosis of diabetes in women with increasing burden of complications.
All right, Dr. Jahagirdar, the next question for you. And pregnancy can be a very emotional experience. If you get diagnosed with diabetes during this period, many women tend to panic. There are also many misconceptions around this. What causes gestational diabetes?
diabetes if she is found to have high blood glucose for the first time during her pregnancy. This is usually diagnosed between 24 and 28 weeks of pregnancy. This hyperglycemia in pregnancy could be either because of undiagnosed type 1 diabetes, type 2 diabetes, or pre-diabetes. This could also be because of some of the hormones that are produced by the placenta, which is the organ which provides nutrition to the baby in the uterus. So the placental lactogen is a hormone which blocks the action of mother's insulin in the body. This leads to insulin resistance, and hence the mother's insulin is not able to work properly in her body. Gestational diabetes is very, very common in India. In some regions, about 1 in 5 pregnant mother has gestational diabetes. The risk factors for gestational diabetes are obesity, if there's a family history of diabetes, if the mother has had a previous pregnancy where the baby was larger than expected, if the mother has had gestational diabetes in the previous pregnancy, or if the patient has had polycystic ovarian syndrome or gained excess weight during this current pregnancy, then the mother is at higher risk of developing gestational diabetes during the current pregnancy. Gestational diabetes, the diagnosis itself can cause anxiety in the pregnant mother, obviously because she is very concerned about the well-being of her baby. But as long as the blood sugars are very well controlled, either with good diet, exercise, and she monitors her blood sugars regularly and comes for regular follow-up with her diabetologist and obstetrician, the complications to the mother and the baby can be prevented. Gestational diabetes usually resolves or goes away after delivery, but the mother is at higher chance of developing type 2 diabetes in the future, and hence we need to keep an eye on these mothers and encourage them to be fit after they deliver the baby.
All right, well, let's talk a little more about gestational diabetes. And Dr. Bhatt, how can gestational diabetes affect a pregnant woman, and what other conditions can a woman with gestational diabetes develop?
Right. So, as said by Dr. Jahagirdar, and you also said in your point, that it is not only medically, but also emotionally, socially, psychologically, and logistically, gestational diabetes can affect a pregnancy. In pregnancy, we would mean that it might affect the lady and it also might affect the child. So the lady has a higher chances of developing complications like hypertension along with high blood sugars during the pregnancy, and the child can also have certain complications because of diabetes during the pregnancy. So here it is important to understand whether the diabetes was present before pregnancy or during the first phase of pregnancy. The effects are different compared to a lady having high blood glucose during the later part of pregnancy. So if the diabetes, either type 1 or type 2, is present prior to the pregnancy or diagnosed within the first phase of pregnancy, the child can develop what we commonly call as congenital malformations, most commonly in the heart of the child, or what we call as abnormal organ development, which happens during the first phase of pregnancy. And the lady might have certain complications related to pre-existing diabetes, and these complications are known to worsen during the pregnancy. So this is how during first phase of pregnancy diabetes can affect. In later half of pregnancy, it is mainly the size of the child that is affected greatly because of high blood glucose. So the child can become large, the fluid around the child can become more than required. At the time of delivery, there are more chances of needing a cesarean section vis-a-vis a vaginal delivery because of the size of the child, or the obstruction of labor during vaginal delivery is also common. So as I said, apart from high blood glucose, you wanted to know what are the other conditions. So high blood pressure causing complications like preeclampsia or fits are common in women with gestational diabetes mellitus. Problems during delivery are common, and worsening of pre-existing diabetes complications are also common. But as Dr. Jahagirdar said, if we do right follow-up, if we keep the right medications, if we take care, the whole family takes care of the lady, most of these complications, it is possible to avoid them.
All right, Dr. Chawla, so if you could also, just tell us a bit more about this issue and what sort of steps do you think women need to take to be better prepared to manage their gestational diabetes?
Great question. I firmly believe that the best way to manage GDM or gestational diabetes that ends up affecting 3 to 4 million women per year in India is by prevention and early detection. Excellent preconception care in consultation with your doctor is a holistic plan, but let me highlight just a few important points. First of all, prevent accidental pregnancies by appropriate family planning. Lose weight or reach your ideal body weight before pregnancy and maintain it throughout pregnancy. Control your blood sugars, blood pressure, as well as cholesterol at an optimal level and have an HbA1c of less than 6% at the time of conception. These are very important. Women at high risk of gestational diabetes, for example, above the age of 25 years or who are overweight, obese, sedentary lifestyle, physically inactive, have previous gestational diabetes or pre-diabetes, have a family history of diabetes, have polycystic ovarian syndrome, or have high blood pressure, all are at high risk and should be counseled really well for the risk of gestational diabetes, as well as the importance of a good lifestyle, blood sugar monitoring, and weight loss. Overall, if you lead a healthy lifestyle, eat healthy, are physically active, check your sugars regularly, also lose weight and maintain before, during, and after pregnancy, maintain A1C, BP, as well as cholesterol and control, plan your pregnancy, and also lose weight after delivery and check sugars regularly and at 6 to 12 weeks post delivery also, then your risk should be contained. For early detection, we have the universal screening program, which is recommended by the Ministry of Health and Family Welfare, with the 75 grams oral glucose tolerance test, which is given to every single pregnant woman visiting her gynecologist for the first time. So these are the keys for preventing gestational diabetes and taking care of oneself and being prepared for a healthy pregnancy with a healthy outcome.
All right, Doctor, well, we'll slip into a short break now. You're watching Health and Wellness, and our special focus today is on women's health. Stay with us. Welcome back. You're watching Health and Wellness and a special focus on women's health in this episode. Let's go across to our doctors. And Dr. Jahagirdar, regular blood sugar monitoring is an essential part of diabetes management. So how many times should a woman with gestational diabetes monitor her sugar levels in a day?
Okay. So regular blood glucose monitoring is very important, and we encourage our patients to monitor their sugars regularly. The reason being, high blood sugars can lead to complications both in the mother and in the baby. Hence, blood glucose monitoring is very, very important, and we encourage the mothers to monitor the blood sugars at home with the help of a glucometer at different times of the day, such as fasting, either 1 hour or 2 hours after their main meals, that is breakfast, lunch, and dinner. We advise them to monitor these blood sugar readings in a diary and share the values with us during each consultation so that we can assess those readings and try and get the blood sugar control within a very strict target range. So the aim of blood glucose monitoring is to ensure that the fasting blood sugar is less than 95 milligrams per deciliter. 1 hour after their meal, it should be less than 140 milligrams per deciliter, and 2 hours after the meal, it should be less than 120 milligrams per deciliter. If the blood sugars are elevated at any point, we try and address their diet and lifestyle, and despite making the appropriate changes to their diet and exercise, if the blood sugars are still high, Then we try and get them in target with either a tablet called metformin or insulin. So they can stop monitoring the blood sugar soon after delivery, and they need to have a blood test done 6 to 8 weeks after they have their baby, that is after delivery, in order to make sure that the blood sugar has normalized.
Right, Dr. Bhatt, though diabetes is characterized by high blood sugar, hypoglycemia is a common complication in diabetes. So can women with gestational diabetes get hypoglycemia, and if they can, how should they manage it?
Right. See, hypoglycemia, what we commonly call as low blood sugar, there is a very strong system in normal body to avoid low blood sugar, because once it happens, it can be very detrimental to the life. So in normal people, in normal pregnancy, the system in the body which prevents hypoglycemia is very strong. So unless the lady is taking insulin, hypoglycemia is not very common. So which is very common, because most of the women with gestational diabetes mellitus, let's say around 70 to 75% of women with gestational diabetes mellitus are able to manage their glucose just on diet and exercise. And if they are able to do so, low blood sugar is a very less likely possibility. Second point to consider is during pregnancy, the blood glucose is generally lower than the non-pregnant state. So a blood glucose below 60 milligram per deciliter would be considered as hypoglycemia or low blood glucose levels, more likely to happen if the woman is taking insulin. So the women who are on insulin need to be aware about blood glucose not going below 60 milligram per deciliter. If that happens, then the treatment is by using a glucose powder. And the dose that generally we consider appropriate is 15 grams, or with a tablespoon, we can say 3 tablespoons of a glucose powder. If the lady develops symptoms related to hypoglycemia like excessive hunger, sweating, giddiness, then she should check the glucose with glucometer. If it is considered below, if it is seen to be below 60 milligram per deciliter, she should immediately consume 15 grams of glucose powder. After that, she can eat to maintain the blood glucose levels. She should meet the doctor to make sure that the necessary changes in insulin are done to avoid repeated episodes of hypoglycemia. It is also said good for these women with insulin to keep a pouch or a tablet of glucose with them all the time, so that whenever this happens, it can be managed immediately.
All right, Dr. Chawla, do the mother and the child have a higher risk then of developing diabetes in the future, especially if the mother had gestational diabetes during the delivery of the child?
So let's understand that diabetes in women has a transgenerational impact. Diabetes, and that phrase that diabetes begets diabetes, is very true for women. An important long-term consequence of gestational diabetes in women is the risk or the increased risk of developing type 2 diabetes. Studies have clearly shown to be precise that this risk of developing type 2 diabetes in women with prior GDM is 10 to 11 times higher, especially in Asian Indian women. And this risk is the highest in the first 5 to 10 years post-delivery. Also, the fetuses that are exposed to maternal hypoglycemia when the mother has GDM are also more prone to developing prediabetes, obesity, and other metabolic conditions at a younger age after they are born. And daughters of these mothers with GDM and their daughters, which is the third generation, are also at a higher risk of developing diabetes, thus perpetuating this vicious cycle of diabetes and affecting at least 3 generations. This awareness and knowledge are very important so that women can intervene with correct lifestyle choices, weight loss or medications, and also exercising a lot, and stop this vicious cycle or break the cycle from diabetes, further leading to diabetes in women.
All right, Dr. Jahagirdar, will a woman with gestational diabetes need tests to check the health of the fetus, and just what are those tests?
Okay, as hyperglycemia in pregnancy can affect the growth of the baby in the uterus, regular monitoring is offered. Like any other pregnant women, at around 20 weeks of pregnancy, women with gestational diabetes are offered a scan called an anomaly scan. This is to look for congenital malformations. This is ideal in a patient who is diagnosed to have diabetes quite early on in the pregnancy. As women with GDM are more prone for polyhydramnias, that is excessive fluid around the baby in the uterus. And they're also prone for preterm labor and higher rates of cesarean section. And the babies are also prone for being a large baby, larger than expected, or they could also have intrauterine growth restriction, that is, they do not grow adequately. These should be picked up in the scans that are offered at 28 weeks. This is a fetal growth monitoring scans and to assess the fetal growth and the amniotic fluid volume. So these scans start at 28 weeks of gestation, and again these are repeated at 32 weeks and 36 weeks. If a restriction of the growth of the baby is suspected, then additional investigations to look for blood supply to the baby, the scans to look for the fetal umbilical artery Doppler, and also to monitor the fetal heart rate, often referred to as the non-stress test. These are offered. This is all highly individualized, and this tests are decided by the obstetrician who is looking after the pregnant mother with diabetes. Soon after the baby is born, the blood sugar of the baby is checked to make sure that the baby is not developing low blood glucose. These are the investigations that are needed to ensure that the baby is born healthy.
All right, Dr. Bhatt, major, if you could answer, briefly, major congenital malformations remain the leading cause of mortality and severe morbidity in mothers with type 1 or type 2 diabetes. What care should women with diabetes take before planning a pregnancy?
The best time to avoid congenital malformations and complications during pregnancy, and possibly complications in the generations to come, is before pregnancy, what we call as preconception care. So a mother's health, control of her blood pressure, control of her blood glucose, control of her weight, correction in her diet pattern, correction in her exercise pattern, reduction of stress are very important before pregnancy to avoid congenital malformations. Often later in pregnancy it becomes very late to intervene, and that is why the best time is before pregnancy. A very important point, if you have diabetes, high blood pressure and cholesterol problems before pregnancy, some of these medications can cause problems in the child as well as mother. So these medications need to be adjusted to be on medications that are safe during pregnancy. So control of parameters and being on safe medications before pregnancy is extremely important for the generations to come ahead.
All right. Well, thank you so much, doctors, for joining us on the program, this special episode of Health and Wellness with a focus on women's health. Thanks so much for watching at home. Goodbye.